This is Dr. Amy Ho, host of ACEP Nowcast. Before today's episode, we want to remind our listeners that registration for ACEP's 2026 Scientific Assembly is now open. Your specialty, your people, one place. Join us in Chicago this October and register now at acep.org/ACEP26 for free access to ACEP anytime.
Ryan Stain here with ACEP Frontline and heading out once again to the 4th Annual Leadership Symposium and EM High Risk Do Not Miss Conference from Colorado ACEP at Beaver Creek, Colorado. And today we are hearing about something that probably gives us a little bit of heartburn, and that is the postpartum emergencies, in this case postpartum cardiomyopathy, with Dr. Anna Engeln. So let's check it out, a little postpartum emergencies and a postpartum cardiomyopathy from Colorado ACEP.
So we're going to move on to the land of peripartum cardiomyopathy. I was trying to decide what I wanted to use as my slide theme, pictures and things like that. My husband reminded me of what I had said right after delivery, which I actually had no recollection of until he's told the story so many times, so now it's embedded in my memory. But apparently right after delivering our son, the nurse said, okay, well, you need to get up in an hour and feed your child. And I apparently said, but I did the thing. And the nurse said, oh, honey, you're not out of the woods yet. So now I associate woods, trees, beautiful plants with the postpartum period. My husband found that hilarious until he realized he was smack dab in the middle of the woods with me as well. And so now we're going to look at some pictures of the woods as we go through this lovely postpartum and end of pregnancy complication. So where are we going? What are we going to look at? We're going to really define what the peripartum cardiomyopathy period is and why the name has changed from postpartum now to peripartum. We're going to go through what is needed for diagnosis, how we evaluate the patient, and what the ultimate treatment is. So first, we do need to look back just a little bit, way back into med school, and review some of the basics of how the body changes during the pregnancy and postpartum period. Taking special consideration of what happens to the cardiovascular system, right? You have incredible increases in your plasma volume, stroke volume, and cardiac output increases by 1.5 liters per minute, like just crazy what the heart is all of a sudden accommodating. A lot of times with this, it's like the stress test that you're having to undergo. So it may uncover some idiopathic underlying issues with the heart, meaning if you have valve disease that you hadn't had diagnosed before, mitral regurg, things like that could really rear its ugly head, or underlying dilated cardiomyopathy that are idiopathic or familial. We are not going to dig into that as much. We're going to deep dive more into what effects pregnancy itself may have on the heart running into this peripartum cardiomyopathy. So peripartum cardiomyopathy, which I have practiced so much so that I don't tongue tangle while I'm talking about this, has gone through many different changes. So initially, it had been slightly alluded to by Virchow, actually, in the 1880s, and he missed an opportunity for a triad because it wasn't actually described until the 1930s. First, it was pregnancy-associated cardiomyopathy or a toxic heart, and then it moved into postpartum cardiomyopathy, and then in the 1970s is where it started to transition from postpartum cardiomyopathy and slowly into the peripartum cardiomyopathy, which is now the most widely accepted term because it best it kind of grabs the entire time period that you would expect. So the formal diagnosis or definition of peripartum cardiomyopathy is the development of heart failure that occurs at the end of pregnancy, so the first 5 months following delivery. And the reason this changed from end of pregnancy, or changed to end of pregnancy initially, was just the last month of pregnancy. One, it's hard to know what your last month of pregnancy actually is, and they were finding that they were missing a lot of potential diagnoses. So this is third trimester, end of pregnancy, up to 5 months postpartum. About 90% of these occur, though, in the first 8 weeks postpartum. So that's the most common time period, but again, you can see this up to 5 months. Again, there's no other identifiable cause of heart failure. So you've ruled out all the idiopathic stuff. This is not right heart strain from a PE that caused this. There's no other identifiable cause. And then the presence of left ventricular systolic dysfunction with an EF less than 45% is essential for this diagnosis. Ultimately, remember, this is a diagnosis of exclusion. So just like Abby said, do your emergency medicine job, work up the problem, consider all the possibilities, but make sure that you're thinking about this as well. If you don't think about it, you're going to miss it. So typical onset, again, we talked about this, and I'm going to really try and drive this home because I think that 5 months postpartum is something we can easily forget as we think more of 8 weeks being the more common postpartum period, right? So end of pregnancy to 5 months postpartum, with the majority being in 8 weeks postpartum. It's the leading cause of maternal death in the postpartum period. So this information is from the CDC population study looking at causes of death in pregnant patients from 2011 to 2015. One thing to pull out of this is every single stage, something cardiac is within the top 3 causes of death. And then as we obviously postpartum or peripartum, cardiomyopathy is going to be at the end, but you see how it really becomes the winner in that postpartum period. The incidence really varies, and there is a lot of speculation as to why. So this can be based off of sociodemographics, access to care, who is able to actually get an ultrasound. In addition, things like diet, general health of the population, what is the incidence of maternal age, and other things along those lines. There's also some cultural differences that may impact this. So actually in parts of Africa, there's a tradition to eat this specialized salt from one of the dry old oceans called kuan, and to eat that within the first 40 days of the postpartum period with all these special soups. So you have this really huge increase in your salt intake, leading to likely hypervolemia, hypertension, so that's another speculated thought as to why things are so high in Nigeria, occurring in 1 in 100 cases. Also, of note, you can get an overnight delivery from Amazon. Unfortunately, the incidence is increasing. So in 2004, we were seeing an incidence of about 1 in 1,100 cases, and this is United States data, 1 in 1,100 cases, and that has increased to 1 in 849 cases in 2011. The other statistically significant finding they found that they uncovered with this study is that the incidence of cardiogenic shock was also increasing. So that's from 1% to 4%. So multiple risk factors have been potentially described. So there's most probable risk factors, meaning these seem to be independently associated with peripartum cardiomyopathy development. This includes twin pregnancy, multiparous or multigravid patients, extremes of reproductive age, and I love that they say that that's over age 30. And actually, if you're over age 40, you have a odds ratio that's at 10 compared to a 20-year-old who's pregnant. So really thinking about this in your extremes of age. Prolonged tocolysis, and this is considered 4 weeks or more of tocolytic therapy. Emerging or proposed risk factors, so this means they've found associations, but they haven't yet determined if this is an independent risk factor itself, and so more population studies need to be done. These include things like smoking, hypertension, malnutrition, cocaine abuse during pregnancy, African ancestry, socioeconomic status, obesity, genetics, and preeclampsia. Definitely a big overlap with preeclampsia itself. So now the pathophysiology. So as with anything multifactorial, it seems like there's a lot of things contributing. Number one, think of your pregnancy-related cardiovascular changes. I do love the quote from Dr. James Martin, who was the chair of Pregnancy and Heart Disease Task Force, who says, pregnancy is the natural stress test, right? So you have this massive increase of your cardiovascular volume that is having to circulate through everything. The placenta is stealing things, like everything is kind of a mess in that in the pregnant and postpartum patient. So you have that's already what you're dealing with. And then you add some other things that we can't figure out exactly what upregulates this. Impaired vascular endothelial growth factor signaling, that may also play a big role, and that is also really involved with preeclamptic patients. So there seems to be a lot of overlap, specifically with the VEGRF. Altered prolactin processing, they have found that when there's a problem with the prolactin, that has increased incidence of peripartum cardiomyopathy in mice. And then inflammatory cytokines, as well as increased oxidative stress. So presentation and evaluation. So this is the fun part, right? So now we've gotten through some of the mud, and now this patient is presenting to our emergency department. So the hard thing with peripartum cardiomyopathy, and why often it can be missed on that initial presentation, is it acts just like some of the symptoms you see with pregnancy, some of the symptoms that you see in that immediate postpartum period. So this is fatigue, mild cough, some pedal edema, P&D, dyspnea on exertion, orthopnea, kind of your basic, I don't feel great, I'm having to carry this all around and I have all this volume that's going on. Physical exam, tachycardia, tachypnea, edema, JVD, third heart sound, a mitral regurg murmur, remember that's your holosystolic murmur at the apex, or rales. So now we're moving into our workup. What do we do with this patient? So obviously you're going to get an EKG in any patient who presents with this shortness of breath or some mild complaints of cardiac symptoms. Most often it's not going to actually be that helpful for the diagnosis of peripartum cardiomyopathy. 50% are completely normal, and the other 40 to 45% are showing just non-specific findings. So some slight T wave changes, some slight ST elevation, some left ventricular hypertrophy might be seen. There are a decent incidence of arrhythmias, and that's because of the dilation of the cardiac muscle itself. Most common of these is atrial fibrillation, followed by ventricular arrhythmias, and you're going to treat those as you would plan to treat them anyway, right, with your beta blockers, amiodarone, electricity if unstable. So we've gotten our EKG. It didn't really help us much. Now we move on to our lab workup. So you're getting your normal, what do I need to rule out and evaluate for labs, right? So you're getting your CBC, you're looking for anemia. Is this a big issue where you're short of breath because you don't have any hemoglobins left because you bled them all out? Is this an infectious thing, although your white blood cell count is very nonspecific? Are we actually dealing with HELP and have really low platelets? And we're also looking at our liver function with the CMP. Looking at renal function, considering a protein creatinine ratio based off of your concern for preeclampsia. And then also getting a troponin that's relatively nonspecific. It may be elevated, but BNP is where most of your money's at in labs. It's hard because your BNP is going to be a little bit elevated in pregnancy, often about twofold what normal is, but no one gets a what's my normal resting BNP or BNP, right, before they get pregnant. So if you see a significant elevation, that increases your concern. If you see a BNP less than 100, that decreases your concern, but neither rules in or rules out, right? A huge, massive PE also can have a huge BNP increase. So where is the money at with this? Echo, ultrasound is the answer to everything, even though I am not an ultrasonographer. And our afternoon will kind of take us through this a little bit more. But any pregnant patient that's in that third trimester or up to 5 months postpartum that comes in with a chief complaint, definitely of shortness of breath, but I would say even consider if you have someone who's just feeling more fatigued and there's an acute change in how they've been doing that made them present to the emergency department, just put a probe on their chest and take a look, right? So for diagnosis, you need an EF that's less than 45%. The LV is often dilated, but it doesn't have to be, or you may see some global dilation, but a decreased EF is really going to help you not, or looking for that decreased EF is going to help you not miss this diagnosis. Chest X-ray is optional. You'll expect to see an enlarged cardiac silhouette, edema, pleural effusion. It can be helpful to look for other causes of that shortness of breath, right? Do you have a pneumonia? Does this look more like COVID? And then you can consider a cardiovascular MRI. This can be helpful if you have suboptimal ultrasound views. So ultrasound is still going to be much better, but a cardiovascular MRI can show can provide some additional information on the left ventricular function. Remember, this is diagnosis of exclusion. So now we're going to look at a couple diagnostic images that have shown up with some of the patients we've seen with peripartum cardiomyopathy. First, your chest X-ray. Remember, this is not necessary for your diagnosis, but things you may see is your cardiomegaly, pulmonary edema. Quick little review of what the heart anatomy is as we move on to our echo. So you're likely going to see some global dilation, especially left ventricular dilation. And I don't think it's not playing, but you can imagine that this EF is a little bit low. Also, the color image is showing mitral regurg. This is one of the important things to look for in these patients, because if you have mitral regurg, harder to see is tricuspid regurg, but that can increase and expedite kind of the failure circle of sadness. One thing I really want to encourage everyone to look for, and this is not part of my routine echo, which it probably should be, but make sure in these patients you're looking at the apex specifically for thrombus. So in about 18% of patients, 16 to 18% of patients with an EF that's less than 35% in the peripartum cardiomyopathy patient, they may actually have an apical thrombus. So be really aware of that. And remember, peripartum cardiomyopathy is a diagnosis of exclusion. So we're considering all of our other things, right? Our dilated cardiomyopathies that are idiopathic or familial. They're going to get a similar workup, but the mechanism is different, so your support of them is slightly changed. Valvular heart disease, have we uncovered atrial stenosis or aortic stenosis? Have we uncovered mitral regurg, especially in rheumatic fever endemic areas? What was underlying that couldn't handle the stress test of pregnancy? What hypertensive disorders are there? Again, do we need the preeclamptic workup? Could this be tachysubos? Does this patient actually need to go for a cardiac cath and see what that looks like? Do they need an infectious workup, blood cultures, respiratory cultures, considering endometrial biopsy for myocarditis? Is this a PE? And this is also where your echo can be extremely helpful, right? Because you're going to see heart failure in your cardiomyopathy. You're going to see right ventricular issues with your PE. So echo can also be extremely helpful in the unstable patient where PE is high on your differential in a patient who's prone to clotting, and helping separate these things out. Also, could this be an acute coronary syndrome from the old-fashioned version of did you just get a normal underlying cardiovascular disease, or could this be a spontaneous coronary artery dissection for which pregnant patients are also at increased risk for? Or could this just be some coronary artery spasm? So this is where a cath also may be beneficial. Again, you do not need this to diagnose peripartum cardiomyopathy, but as you're looking through and thoughtfully considering all the differential, this might be something you need to do. So now on to treatment, right? So everyone knows how to treat heart failure. We could do it in our sleep. Super easy, right? You reduce the afterload, you optimize your preload, you support cardiac contractility, prevent thromboembolic events. But now your patient is pregnant or postpartum and it becomes all of a sudden super scary, right? If anyone knows what that is, super scary. So this flow chart, and I'm going to break it down a little bit more because I know this one's pretty busy. This is actually from the European cardiac guidelines. So there's a couple medications that we don't use that are on here. But I think it's really helpful in looking at our approach to the patient. So first, what we do best, we have two big questions. One, sick or not sick, right? So assessing how do they appear, what are their vital signs, are they hemodynamically stable? Are you seeing either clinical or laboratory signs of shock, such as an elevated lactate? What's their mental status? Are they cold? How are things looking? What's their urine output? And then you want to confirm the diagnosis, right? So we're doing our labs, our BMP, our ultrasound, EKG, considering chest x-ray. And now, in this patient who is unstable, we ask the next question, are they pregnant or not, right? So first question, stable, unstable. Second question, are you pregnant or are you not pregnant? So we're going to start off with a scary patient, right? This is the one that needs our attention first and foremost. So this is the unstable patient who presents with severe shortness of breath, and now you've ruled in your diagnosis for peripartum cardiomyopathy. As you've ruled out some of the other things, you did your ultrasound that shows a significantly decreased EF. I want to actually optimize oxygenation to number one, right? Because heaven forbid we ever go anywhere without doing ABCs first. So first you want to optimize the oxygenation of this patient. So this is a patient that you're placing on oxygen, really early use of your non-invasive positive pressure ventilation. Often that's all you need. If you're unable to succeed with appropriate oxygenation, meaning above 88 to 90% here in Colorado, obviously that number will change based off where you are, then you can consider intubation, recognizing if the patient is still pregnant, this is a very high risk and thoughtful intubation that you're doing. You want to optimize your preload, right? And then if your blood pressure is too high, you want to fix it. Beta blockers, hydralazine are a great option for that. If your blood pressure is too low, you want to fix that as well. So milrinone, epi, norepi, dobutamine are all perfectly fine. Dopamine is also, it's not explicitly mentioned as your primary treatment goal with peripartum cardiomyopathy. However, it is safe in pregnancy and in breastfeeding. So if that's the only thing you have available to provide that additional inotropic support for the heart, you can grab that, although dobutamine would be your first choice. The consider bromocriptine, we'll talk about that a little bit more. That's more of a European drug and is not used in the US, and I'll talk about that a little bit more in a moment. So some of the big considerations. So as soon as you're like, ooh, I need to start this patient on pressors, they are not looking good. You have two other big questions to ask. Is this a patient that will need urgent delivery, and where do I need to have this patient for that to occur, right? So if you are at a freestanding in Avon, that's probably not where you want any of these things to happen. The other question you have is, if my additional medication support for increased cardiac output is not working, my next step is then going to be mechanical circulatory support like ECMO or an intra-aortic balloon pump or something like that. So those are the two questions you're now thinking of. My patient starting that spiral, I want to make sure they're in the right spot if this continues to go wrong. So you want to do that before you're adding your second pressor or you're intubating your patient. You're wanting to start getting them to the right location. One of the big things I want to point out with pregnancy too is you want to avoid ACE, ARBs, spironolactone and things along those lines, because those can have really severe effects in pregnancy and are contraindicated. So just make sure you're not reaching for some of those more things that you'll normally use in heart failure. You want to be really thoughtful that in this patient population, you do not want to use those. They interfere with fetus and kidney development and function. That can lead to low amniotic fluid levels, poor lung development, skull hypoplasia, and even death of the fetus, which no one really wants. So now we've stabilized and are initiating transport if needed for our very sick, unstable peripartum cardiomyopathy patient. And we take a breath and walk into our next room, and it's apparently an outbreak today, and we have a nice, stable peripartum cardiomyopathy patient. So there's no cardiopulmonary distress. Vital signs are all stable. So now we've moved to our second question with this one of, are you pregnant? Are you not pregnant? Because this is going to make a big difference in your medication choice. Again, remembering ARBs and spironolactone are not recommended in the pregnant patient, but are fine with breastfeeding. This is a nice review of what medications are safe during pregnancy as well as during lactation and potential adverse effects. The green ones have been well studied, so your loop diuretics, beta blockers, hydralazine, nitrites, digoxin, those are all very safe within the whole gamut of still pregnant or postpartum patients that are breastfeeding. And your ACE, ARBs, spironolactones, those are not safe, and they have data that's very concerning, and actually they're contraindicated. So now anticoagulation, right? So very high risk for clotting in this patient. Not only are they on the procoagulo path of pregnancy, but now they have the additional risk of 16 to 18% of patients potentially developing an additional thromboembolism. So anticoagulation is definitely recommended within the first 8 weeks of this diagnosis. So remember, if they're still pregnant, you want to go with low molecular weight heparin. If they're not, you want to go with warfarin, making sure you have that bridge. So as I alluded to a little bit before, there's this thing called bromocriptine, and it is not used routinely in the United States, but is controversially used in Europe. So what it does is it inhibits prolactin secretion from the pituitary, so it's been shown to prevent the development of pericardium cardiomyopathy in mice. So they've used it on rare occasion to try and decrease one of the potential causes. However, it is not without really potentially severe side effects. So it completely stops breast milk production, which is one thing you may have heard it for, because it will stop breast milk production. The other thing is it's also procoagulant. So not only are you now pregnant, but you also have pericardium cardiomyopathy, and now you're adding a medication. That's another, you're going to get a blood clot thing. So really has some potential harm to it. One of the reasons it's not recommended here. There are ongoing studies primarily in Europe, so we'll see where that goes. Overall prognosis. So one of the good things with peripartum cardiomyopathy, although it is the leading cause of death in the postpartum period for patients with a mortality of 4 to 10%, one of the overall good things is it's actually one of the best recovered cardiomyopathies of all the ones that exist, right? Because you get rid of a lot of this pregnancy mumbo jumbo hormone, and by 6 months, about 50 to 60% have returned to full recovery, full baseline. Persistent symptoms may occur in 25%, and this would just be like, oh, you probably can't walk up multiple flights of stairs, but they're not really impacting your ADLs. Complications do occur in about 25% of these patients, which is why this is no laughing matter, right? So progressive heart failure, cardiac arrhythmia, thromboembolism, and again, the mortality range is 4 to 10%. Patients should get an echo at 6 weeks after diagnosis, and then again at 6 months, and if not completely returned to normal, then at 1 year. If that's normal, it has a very good prognosis. If the EF is still less than 35%, or if they had an EF, or less than 50%, or if the EF was less than 25% when they were first diagnosed, that has poor prognosis. So what happens next too? So on these patients in future pregnancies, right, you see your first trimester patient who's pregnant, and this is on their, oh, you had this last time list. What does that mean? So if they had a fully recovered EF, again, greater than 50%, only about 20% will have a relapse, and it's not necessarily worse than it was before. Obviously, this patient should be being followed by MFM, but that severe deterioration is pretty rare. Non-recovered, so this is the EF that stayed greater than 50% or was less than 25% at time of diagnosis, they have an extremely high risk of relapse. So subsequent pregnancies aren't necessarily recommended. Obviously, that's a decision that the patient can make with their MFN. But they see significant, meaning over 50% of these patients will have a much more severe deterioration than where they had before. A significant increase in morbidity and mortality. So just kind of that brief overview. The big thing I want to really put in your minds, up to 5 months postpartum, right? End of pregnancy and up to 5 months postpartum is where we really should be considering your pericardium cardiomyopathy as a cause of increased fatigue, shortness of breath, lower extremity edema in our patients. That big, huge thing of echo, ultrasound is what's going to be the real determinant of where to go, how sick this patient is, and be able to fully make your diagnosis. As you're treating the patient, think of sick, not sick. Make sure you manage your ABCs first, and then consider what medications you have and what's appropriate in pregnancy, making sure to avoid your ACEs, your ARBs, your spironolactones in pregnancy. And then finally, where does this patient need to be? This is early consideration of transfer if they're starting to decompensate and prior to them getting really decompensated to a place that's able to provide more support like ECMO if they're unable to support them with just medications. And then being very thoughtful about next steps with pregnancy, and anticoagulation is the key to it all, so making sure that you don't make things worse.
Postpartum Emergencies and Postpartum Cardiomyopathy with Dr. Anna Engeln from the Colorado ACEP 4th Annual Leadership Symposium and High Risk Do Not Miss Conference, taking place once again in November this year. I will be there as a speaker, so please come out, join us, and enjoy. Be happy to meet with you and take in some of this great content every single year. This conference has some fantastic education, and I encourage you to look at some of the local and state-based, and especially those conglomeration of states conferences as great local content, great locations, several that I attend on the regular, and several more to come. So check it out. As for me, contact me, rstanton@acep.org, rstanton@acep.org. You can check us out on Facebook on our ACEP Frontline page, and then also please download and subscribe to the podcast on the regular, and encourage your friends and colleagues and coworkers to do the same. Leave us a 5-star review, and until next time, I'm Dr. Ryan Stanton, and this has been some ACEP Frontline.
Far away to a quiet If you're not on the front lines, you're on the sidelines.
Cue the music.
Bow, bow, bow.
There. Quiet place, all
Yeah.
alone. Da, da, da.